So here we are in the largest convention of intensive care medicine worldwide, about 10,000 participants. So the European Society of Intensive Care Medicine meeting is the place to be when you're intensivist once a year.
We were incredibly lucky to have Professor Djillali and Annane host the session for us. Djillali is a world leader in sepsis, and it's wonderful to have him as a champion in our corner. With the test we've done, we're proving that the H3.1 we're detecting in sepsis is coming from neutrophils. So that's bringing us back to that signal that the H3.1 is a marker of immune activation in sepsis. And then we showed our clinical data. Clinically, there's a signal to death, and that's across 3 distinct data sets. So independently found that, which gives it tremendous power. And then again, there was a signal towards renal injury, acute kidney injury in those data sets, and there was a signal towards respiratory failure as well. Looks like the H3.1 signal goes up early, so it might be really predictive of a patient's trajectory and journey. It gives you a bit more time to intervene and improve a patient's clinical course and trajectory. That's what we all want to do.
Sepsis and septic shock is probably the most common thing that I treat on a day-to-day basis. By understanding which patients are going to demonstrate real significant deterioration earlier, they're the ones that we really need to intervene on, and we can stave off deterioration quite quickly. Either preventing admissions into intensive care or shorten their intensive care stay, and then getting better outcomes for more people.
It's the first time I have seen so many data coming so fast and with consistent findings. So what we are likely to see now with H3.1 and more globally with NETs measurements is a high likelihood of getting a treatable threat, a game changer in effectively modifying patients' trajectory.
I'm dealing with extracorporeal blood techniques, so we are providing a lot of them, and they're the novel technique of their elimination of their nets. It's very promising, so it was very important for me to understand that now we got their new tool to evaluate, to measure the level of their chromatin-derived molecule substances. This is very promising, and we are waiting for results and outcomes.
It works in K2 EDTA plasma. It takes a very small amount of volume, and so it's something that can easily be added on to existing panels. It uses an immunoassay, so it can be done very rapidly and also very cheaply.
Things had to be feasible at the bedside without being cumbersome. So that's a major issue. And indeed, with the NuQ technology, that is achievable. So I think this is something that is very likely to be translated by most physicians like me in their routine practice in the next couple of years or so.
It does what it says on the tin. It works. It's testing what it's supposed to. We can turn it around in 15 minutes. It shouldn't require any extra special technology. It should be easy to adopt and embed in our routine clinical practice. There's more work to do to prove the clinical case, but that's a really great start. We're sort of ahead of the curve now, which is great.